Good afternoon to everyone. It's a pleasure for me to introduce today Dr. Anna Ardissone, who is a child neurologist. She's working at the Neurological Institute Carlo Besta in Milan, and she has a long experience in metabolic and neurodegenerative pediatric diseases. And today she will talk about mitochondrial leucoencephalopathies. Anna, please.
Okay. Good afternoon, everybody. Thanks the organizer to invite me and to Dr. Lamorgia to introduce me. So today we are going to talk about mitochondrial leucoencephalopathies, a topic interested both by clinicians and radiologists. I'm a clinician, so I would like to share knowledge and experience from a clinical point of view to give you an update of an overview, updated and useful of mitochondrial leucoencephalopathy for clinical practice. I have organized my talk in 4 different topics, an introduction and an overview of general findings of this kind of disorder. Second, focus on main phenotypes related to the age at onset and so of specific interest for childhood and adulthood neurologists, underlying differential diagnosis. And then a few examples of peculiar MRI patterns and of often treatable condition. So going to the first topic, first of all, what do we mean by mitochondrial leucoencephalopathy? We know that leukodystrophies are genetic disorders related to nuclear DNA, primarily involving the white matter of the central nervous system, with high clinical and genetic heterogeneity. Most leukodystrophy are characterized by a specific combination of affected structure on MRI, and so often MRI patterns addressed to the genetic diagnosis. On the other hand, we know that mitochondrial encephalopathies are genetic disorders, again, but not only related to nuclear DNA, but also to mtDNA, mitochondrial DNA, with high clinical and genetic heterogeneity again, but they may manifest with different involvement of central nervous system. So we know that there are conditions related to lesions of gray matter, for example, Alpers-Lee syndrome, and other that shows primary white matter involvement, like Kearns-Sayre syndrome, Mingy, and some Ox-Fox defects, which are known from a long time. But recently, the advanced genetic techniques have revealed that numerous unsolved cases of leukodystrophy have a mitochondrial etiology. So, talking about mitochondrial leukodystrophy or mitochondrial leucoencephalopathies, we mean encephalopathies with MRI and clinical pattern suggestive for leukodystrophy, resulting from a gene defect responsible for mitochondrial disorder, both in nuclear or mitochondrial DNA. To date, mitochondrial leucoencephalopathy represents about 5 to 10 of all genetic leukodystrophies. And why do mitochondrial dysfunction lead to white matter damage? We know that mitochondrial function are crucial for all subtypes cell of white matter, not only for the neuronal high energy demands, but also for oligodendrocyte differentiation and viability, microglia activity modulation, astrocytic function regulation, especially neurotransmission. And so the alteration of the multiple mitochondrial dysfunction in all these subtypes cells lead to the tissue damage. The link between leukoencephalopathy and mitochondrial disorders had been firstly disclosed at the end of the 80s. About 10 years later, other reports were described, and at the beginning of 2000, Kang and other colleagues described the first case series of mitochondrial leukoencephalopathy in children, introducing the issue of differential diagnosis of the issue of mitochondrial leucoencephalopathy among differential diagnosis among genetic leukodystrophy. In this slide, we can see the data about the frequency of mitochondrial leucoencephalopathy in children. As you can see, there are several case series of mitochondrial disorders in children reported in the last 20 years. In each of these case series, the incidence of leukodystrophy had been analyzed. And as you can see, there is an increasing number of these incidents, except for the last paper, Sharma et al. This most recently published cohort includes also adults, and so not only children. Indeed, we know that the frequency of mitochondrial leukodystrophy in adulthood is lower than in childhood. There are a few reports about these topics, but the conclusions are the same, reporting the mitochondrial leukodystrophy no more in 5% of genetic leukodystrophy and mitochondrial disorders both. But which kind of MRI pattern we see in mitochondrial leucoencephalopathy? The alterations are suggestive for dystrophic involvement, and so hyperintense in T2 sequencing and hypointense in T1 sequencing. And the sites of the first alteration depend on the age of onset of the disease in relation with the centrifugal myelination direction. And so we can observe the deep white matter involvement in infantile cases and subcortical white matter involvement in the disease with onset later, and for example in juvenile age. In this paper, the MRI patterns of mitochondrial leukodystrophies are described in a large cohort of patients, 132 patients. This study included children and adults. As you can see, the most common biochemical and genetic diagnosis is related to complex 1 deficiency, to iron-sulfur cluster pathway, and to MT deletion, and so related to Kearns-Sayre syndrome. Analyzing several MRI studies of this cohort, the authors concluded that there are some abnormalities suggestive for mitochondrial disease, which were commonly observed, and they are the involvement of middle blade of corpus callosum, the cerebral white involvement associated with the cavitation, the association also of involvement of deep gray matter, brain stem, and the presence of symmetric abnormalities in middle cerebellar peduncles. But on the other hand, the authors didn't find a specific MRI pattern for each gene, and so they conclude that MRI pattern and genetic genotype correlation is lacking. Indeed, we know that to date a high number of genes has been associated with mitochondrial leukodystrophy, more than 30 genes today, both in nuclear DNA and mtDNA, and also the well-known leukodystrophy in Kearns-Sayre associated to large deletion of mtDNA. As you can see, there are not only gene encoded for subunit of respiratory chain, but also gene related to other function of mitochondrial biology, of metabolism, of cofactors, for example, apoptosis regulation, CoQ10 biosynthesis, and so we know there are also mitochondrial leukodystrophies not associated to deficiency in respiratory chain. Starting from this point, that these 2 points, that there is no MRI specific MRI pattern, and so there is no radiological classification. And on the other hand, a lot of genes responsible of mitochondrial leukodystrophy. We know that to date, the only available classification of mitochondrial leukodystrophy is based on the altered function, and so from a genetic point of view. But moving on clinical setting, when do we have to think about mitochondrial leucoencephalopathy evaluating our patients? And so when we have to suggest this kind of diagnosis. So we move on the second topics, analyzing the main phenotypes related to age at onset. As we said before, the adult onset is no frequent in among mitochondrial leukodystrophy, but it is very typical and often associated to a specific syndrome that is mitochondrial neurogastrointestinal encephalopathy syndrome, known also as MNG. This is a rare disease due to TIP mutation, lead to deficiency of thymidine phosphorylase, and so thymidine and deoxyuridine accumulating and leading to impairment in mtDNA maintenance and integrity. The onset is usually between the first and fifth decades, and the clinical picture is very complicated, characterized by severe gastrointestinal dysmotility, cachexia, ptosis, external ophthalmoplegia, and sensory motor neuropathy. But the very typical aspect is the presence of leukodystrophy. In this slide, you can see an example. This is the MRI study of a patient of 27 years old. As you can see, there is a bilateral and symmetrical diffuse cerebral white matter involvement with a relative sparing of subcortical EU fibers and the involvement of cerebellar white matter also. The important finding of this leukodystrophy is that it is completely asymptomatic. The patient may manifest neurological symptoms, as we say, ptosis, ophthalmoplegia, and sometimes ataxia, but no pyramidal signs. Moving on, childhood and juvenile onset. The most common leucoencephalopathy is the Kearns-Sayre syndrome. This is a rare sporadic mitochondrial disease caused by a large-scale mitochondrial DNA deletion, and so for this is sporadic. The onset is generally before age 20, and the clinical features include the progressive external ophthalmoplegia and retinopathy, cerebellar ataxia, sensory hearing loss, and extra neurological symptoms, first of all, heart blocks and renal involvement and endocrinopathy. The MRI pattern in this kind of disorder is very typical, characterized by involvement on the cerebellar white matter and subcortical cerebral white matter with selective involvement of EU fibers. There is also association of involvement of basal ganglia and thalami, and often it is possible to observe a lactate peak at spectroscopy. But another typical radiological pattern is the involvement of cervical spinal cord and also of the spinal trigeminal tract. So we are talking not only about a leucoencephalopathy, but a leukomyeloencephalopathy with a specific pattern. Moving on, infantile onset, the situation is increasing in knowledge about this. About this topic, I share with you the analysis of a cohort of our patient. This is a study performed on mitochondrial disease with early onset, studying 240 patients. As you can see, the more common phenotype is Lee disease, as expected, but 7% of patients presented a pattern of leucoencephalopathy. The patient presented onset generally after a free interval with or without a trigger and before 1 year of age. The most common symptoms and site at onset was psychomotor regression, psychomotor delay, failure to thrive, and the clinical picture in time are characterized by the association of pyramidal signs, central hypotonia, and psychomotor or cognitive involvement. In half of patients, the outcome was stable after the acute phase. And this is an important point, different from other mitochondrial disorders in children and the Lee syndrome, first of all, in which the outcome is unfavorable. These are the biochemical and molecular diagnoses achieved in our patients. The most common biochemical and molecular diagnoses were associated to complex 1 deficiency or observed in normal activity of respiratory chain complexes, generally related to mtDNA maintenance and gene expression nuclear gene. This distribution is quite similar to another case series described a few years ago among 40 patients. Sorry. Okay. So, which common MRI findings we observed in our cohort? There are some common MRI features, the T2 hyperintensity and the T1 hyperintensity abnormalities, so suggestive for leukodystrophy pattern, as we said before, with cerebral, deep and periventricular white matter involvement, and also brainstem and cerebellar lesions, mainly in the middle cerebellar peduncles. Moreover, we observed the multifocal diffusion restriction, and in 60% of cases, other radiological alteration were associated. The most common were the cystic degeneration and cavitation, followed by cortical malformation and subcortical atrophy. So, looking at a few examples of our series, we can see in the first MRI the picture of a patient with complex 1 deficiency by associated to nuclear DNA gene. We observed the diffuse white matter involvement and the cystic degeneration. Also, the picture is quite similar in this patient affected by complex 3 deficiency associated to LIM7 genes, and in another patient with complex 4 deficiency, we can see important cavitation in the white matter and also in corpus callosum. This is a very peculiar case because the first leukodystrophy associated to mitochondrial DNA gene. But as the cystic degeneration often associated to mitochondrial leukodystrophy pattern in infantile cases is an important point to underline because it is common also in other genetic leukodystrophy. And so they are important to address the differential diagnosis. The characteristics is different in cystic degeneration observed in mitochondrial disorders despite other genetic leukodystrophy. I share some example. The cavitation in mitochondrial disorders has are multifocal, as we can see, well delineated and generally located in the periventricular and deep white matter. In vanishing white matter disease, they are generally diffuse and without a well-defined rims. And in Alexander leukodystrophy, the cavitation are mainly located in the deep frontal white matter and generally may become quite large. Another important point related to differential diagnosis is the involvement of corpus callosum. In mitochondrial leukodystrophy, generally is involved the middle brain with sparing of inner and outer blades. In vanishing white matter leukodystrophy, generally there is involvement of middle and inner blades with sparing of outer blade. And in adrenoleukodystrophy, in which the splenium corpocallosum is a radiological hallmark, we can see that generally all layers are involved. And so this observation may be useful for differential diagnosis. So summarizing the findings of mitochondrial leukodystrophy in children, we know that they present an acute or subacute onset after free interval with or without trigger. The clinical symptoms at onset are generally psychomotor regression and hypotonia, and clinical picture in time is characterized by pyramidal tetraparesis and cognitive impairment. This picture generally is stable after the acute phase. At MRI, it is possible to observe a diffuse white matter involvement of both sovereign subtemporal structures associated with cavitation. Several genes are associated to mitochondrial leukodystrophy in children, more often related, encoded by nuclear DNA, and differently from adult patients. But despite of several causative genes, MRI pattern genotype correlation is lacking, and it is important the differential diagnosis with other genetic leukodystrophy with a similar clinical picture at the timing of onset. Talking about differential diagnosis, another important point is the spectroscopy. The spectroscopy is useful in mitochondrial disorders because it discloses the lactate peak. So we performed a study of 25 MRI of patients affected by mitochondrial disease, and we found almost all patients with leukodystrophy with lactate peak and less than half of polydystrophy with lactate peak. So this data suggests useful of spectroscopy in leukodystrophy's mitochondrial compared to polydystrophy's mitochondrial. The second point is that generally the lactate peak is absent in other genetic leukodystrophy. So the answer to our question is yes, the spectroscopy is useful for radiological differential diagnosis of mitochondrial leukodystrophy versus other genetic leukodystrophy with similar MRI pattern and clinical features. A second point to underline about this question is the presence of succinate peak that is typical and specific for succinate dehydrogenase deficiency, also known as mitochondrial complex 2 deficiency. It represents about 2 or 3% of all mitochondrial encephalopathies and is associated with mutation in four genes, generally to SDHA and SDHB. The succinate dehydrogenase deficiency is associated with different clinical presentation, including Lee syndrome and leukodystrophy pattern, with the typical succinate peak at the spectroscopy. So again, the spectroscopy is useful for radiological diagnosis and is a specific and pathognomonic for the radiologic diagnosis of succinate dehydrogenase deficiency. So let's go to the third topic. We said that there are peculiar patterns of leukodystrophy in the adulthood, for example, Minji, in juvenile onset, for example, Ken-Sayer, but we say that there are common features in leukodystrophy with infantile onset. But it is important to add that there are some peculiar MRI patterns, and so we saw now a few examples. The first is NUBPL-related leukodystrophy. NUBPL is a nuclear DNA gene encodes for iron-sulfur cluster assembly factor of complex 1, so it is associated with complex 1 deficiency. Generally is associated with childhood onset. And the peculiar MRI pattern is characterized by the association of the hyperintensity of cerebral cortex and cerebral white matter. So as we can saw before, diffuse cerebral white matter involvement is frequent. The presence of T2 hyperintensity of cerebral cortex is often observed in mitochondrial disease, but the association of these two kinds of radiological findings is very peculiar and pathognomonic of NUBPL-related leukodystrophy. Another example of a specific pattern is CARS-related leukodystrophy. CARS is a nuclear gene encodes for lysine tRNA synthetase. It is being reported with associated with different phenotypes. Peripheral is isolated peripheral neuropathy, firstly, non-syndromic hearing loss, encephalopathy with different degree of clinical severity, late onset leucoencephalopathy and cardiomyopathy. And recently we described a cohort with a common clinical picture characterized by early onset and progressive encephalopathy with acquired microcephaly, development delay, pyramidal signs, epilepsy, hypoacusia, and visual impairment associated with extra-neurological involvement, anemia, failure to thrive, and liver involvement also. But in this patient, we identify the typical and common radiological pattern, which is characterized by, we show now the MRI of the same patient at the onset and 1 year and 9 months of age. You can observe the deep cerebellar white matter involvement with the middle cerebellar pedunculus involvement and of course cerebral deep white matter involvement. About 2 years later, the same patient presented a worsening of white matter involvement and the presence of an important diffuse cerebral atrophy with ventriculomegaly and important also cortical atrophy. But the very peculiar radiological aspect of these patients is the presence of calcification, a lot of calcification with an important distribution in all structures of brain and not only brain. As you can see, calcification in the cerebellar white matter, in pons, in cerebral white matter, in internal capsules and semivalute centrum, and not only brain calcification, but also calcification along the whole spinal cord. And this peculiar radiological pattern of a leucoencephalopathy with the brainstem and spinal cord calcification is pathognomonic of this kind of CARS-related leukodystrophy. So, moving on the last topic, we are talking on mitochondrial disease. Mitochondrial disease, by definition, are untreatable condition, but there are a few and selected cases in which targeted therapy may modify the natural history of the disease. And so it is important to know this because it's important to achieve early diagnosis. I share the case of our two patients. This is two children with a very similar history. The first is a female with normal psychomotor development. At 14 months after a trigger factor, she presented psychomotor and language regression associated with neurological signs, acute left hemiparesis, loss of postural control, and an important dysphagia. This is the MRI, diffuse white matter involvement, and initial cystic degeneration. The second patient presented some problem at the birth, and so he developed a mild psychomotor delay, but at 2 years and 9 months after another trigger, he developed ataxia, dysarthria, and language regression, and this is the MRI of the children. As you can see, there is deep white matter involvement and initial cavitation. In the diagnostic workup, this patient elevated lactate level were detected, and so mitochondrial disease were included in diagnostic workup. And in both cases, a complex 1 deficiency was detected associated to two different nuclear DNA genes. After diagnosis, the patient started treatment with cofactors. And what about the follow-up? They start with dosage that increased in time up to 500 milligrams each day for about riboflavin. And at the following follow-up, an important clinical improvement were observed. In the first patient, after 15 months, the first patient after 50 months showed only mild distal pyramidal signs. After 5 years, she developed a mild cognitive impairment, and this picture was stable in time until the last follow-up after 17 years from the onset. The second patient presented after 13 months normal neurological examination, a normal IQ, and was stable in time with a total follow-up of 16 years. Also, lactate level became normal. What about MRI of this patient? This is the radiological follow-up of the first patient. This is the MRI at onset. As you can see, there were also a cavitation corpus callosum in deep white matter. At the first follow-up, after 1 year of treatment, there was an important reduction of white matter abnormalities, and that was more important in the following follow-up and remained stable at the last one. This is the radiological follow-up of the second patient. As you can see, there is also a reduction of white matter alteration, and MRI became quite normal at the following MRI studies. It was characterized also by a mild periventricular white matter involvement. Another example, these two cases are the example of our clinical experience, but they were not the first reported in literature. To date, there are 8 patients were described across 6 anecdotal studies. 7 patients were symptomatic with pyramidal and cerebellar signs and psychomotor involvement. Only 1 patient was asymptomatic, and diagnosis was made after an MRI study for an head trauma. All symptomatic patients presented onset before 1 year of age, and the diagnosis of complex 1 deficiency was achieved in each patient related to nuclear DNA gene encoding for complex 1. The patient started treatment with riboflavin with a different dosage, and the outcome showed a clinical improvement in all symptomatic patients. The asymptomatic patient did not develop signs or symptoms, but the challenges of this data are that there are no neurological follow-up data. Or the MRI follow-up was available only for the asymptomatic patient who remained stable. Another example of hopefully treatable mitochondrial leukodystrophy is the example of Minji. The treatment is suggested is the hematopoietic stem cell transplantation, based on the idea that donor-derived cells are rich in thymidine phosphorylase, and so thymidine phosphorylase from normal donor cells could clear thymidine and deoxyridine from plasma in this patient. Starting from this point, 26 patients were treated with hematopoietic stem cell transplantation. 2 patients died from condition-related complication, 9 for complicated related to transplantation, and 6 patients died for disease progression. 9 on 26 patients remain alive with a different follow-up. In the follow-up, good clinical outcomes were reported, an improvement in general condition in all patients with related to the general health. There also improved of gastrointestinal symptoms was observed in most patients, improved of neurological function, and particularly of ophthalmoparesis and ptosis. Cognitive impairment remains stable or normal in all patients, and the neuropathy improved in the whole cohort. What about MRI? And so about the leukodystrophy, that is topic of this talk. Brain MRI, first of all, was available only for 6 on 9 patients. At the first follow-up, 3 patients showed a slight increase and so worsening in white matter abnormalities. But at the last follow-up, after 4 years from transplantation, 1 patient white matter involvement improved, and in 5 patients remained stable. So starting from this, the latest guidelines recommend the hematostem cell transplantation as an effective treatment that restores the biochemical imbalance, but it requires important chemotherapy and immunosuppressive therapy, and is associated with a high risk for complications related to this treatment. So, summarizing, talking about mitochondrial leucoencephalopathies, we can say that they represent a specific and relative novel mitochondrial disease phenotype as Lee syndrome, Alpert syndrome, with increasing incidence on all mitochondrial diseases. They are more common in childhood than in adulthood, but in adulthood and in juvenile patients, there are pathognomonic conditions such as Meninge and Kearns-Sayre syndrome. In children, leukodystrophy are more common, but there are several genes related to this kind of disorders, only a few peculiar patterns, but MRI pattern and genotype correlation is lacking. In a few selected cases, targeted treatment can modify natural history, but large cohort studies are required to improve knowledge about this kind of disorders. And about this, I'm working on an observational study on mitochondrial leucoencephalopathy, with the aim to describe natural history and genotype-phenotype correlations. Today, we have collected about 200 cases from Italian network of mitochondrial disease. And so if you are interested in this study, you can share your data and contact me to my email. And so thanks for your attention.
Thank you very much, Anna, for this very interesting presentation. Let me see if there are any questions in the chat. I cannot see here, maybe here, not here. So maybe there is someone still thinking about, I can ask you something. Which is your opinion in terms of the role of muscle biopsy in those cases presenting with just leukodystrophy as main clinical feature? Do you think it's still a valuable role? Do you think it's worth to do it in the diagnostic pathway?
Yes, thanks for this question, because I didn't talk about the diagnostic workup that is changing in this year. I think that the muscle biopsy is important and necessary in some kind of disorders. For example, in Kearns-Sayre syndrome, the deletion of mtDNA, it is possible to detect only on the elective tissue is muscle and non peripheral mtDNA. So without muscle, not performing muscle biopsy, it is possible to miss this diagnosis. And about the other mitochondrial leucoencephalopathy, I think it depends, because as we can see, there are part of condition associated with OXPHOX defect, and so muscle biopsy may address to genetic analysis, but there are a lot of conditions in which the activity of a respiratory complex chain is completely normal, and so it's the biochemical study are not useful. So I think this is some condition in which it is necessary, other in which it depends also on the possibility of to study this kind of patient. Okay. But despite the 10 years ago, it may be less necessary and useful.
For the diagnosis. Okay.
Yes.
There is a question from Pablo Garrigos. Could cases from outside Italy join the study, and what's the time frame of the study? Is the study that you mentioned at the end?
Yes. Okay. Yes, we are. You are happy to collect more data, and so of course we start in Italian net to collect data in Italian network. But as we saw, it is important to describe a major number of patients to improve knowledge about this topic. So welcome for data outside of Italy, and you can contact me by email. So any people who has some cases, we are starting now to analyze results. So we have a lot of we have time to collect additional data.
Okay, perfect. So there is another question from my Abu Eikal. I don't know if I pronounce it's good. Is there a role of mitochondrial cocktail in these patients? So the use of
Yes. As I show in the cases of patient with complex 1 deficiency, the rationale to prescribe mitochondrial cocktail and first of all riboflavin is important, and in some cases, as the cases riboflavin responsive, change the natural history. So I think that but it is a common opinion of the international community. It is important mitochondrial cocktail when there is in a patient with a diagnosis of biochemical defects, riboflavin for complex 1 deficiency, the thiamine for deficiency of complex 1, 2, and coenzyme QDH for complex 1, 2, and 3 is because it's a cofactor, as we know, of these 3 respiratory chain complex. Maybe the situation is different for the cases with a normal respiratory chain activity, but I think it's better to prescribe because it's a well-tolerated treatment.
So it's worth to try riboflavin for complex 1 defect, that's for sure.
Yes, of course.
Okay. So I think there is another question from the chat. Someone wants to make a voice question. Yes, please. Cinzia? Maybe you Elizabeth, you should unmute.
Cynthia, you have to unmute yourself.
Okay.
Maybe it's an error, so we can move on. And
okay. Let me see if there is any other from here. No. So maybe just for last question, Anna, you mentioned that it's very difficult to find a genotype-phenotype correlation for these conditions. And also there are some specific leucoencephalopathy patterns, but not for all the genes. Do you think there are some clinical and neurological clues that helps in diagnosis, in the differential diagnosis from acquired leucoencephalopathy?
Yes, this is another important topic. First, because the different treatment, of course, because acquired conditions are really treatable disease. I think the clinical presentation, the age of the patient, first of all, may be useful to address differential diagnosis, because generally the acquired conditions are characterized by acute or subacute onset associated to a trigger factor often, and but they are more and this is typical onset of mitochondrial leukodystrophy, but in childhood. While the typical clinical presentation of acquired condition is typical of the juvenile of adult patients. So this is important, the different age, even with similar clinical onset. The second point into the characteristic of the finding of the radiological finding. Generally, acquired conditions are not associated to cavitation, and an important diagnostic tool is the positive for enhancement, which is possible in mitochondrial and generally metabolic leukodystrophy, but it's rare and different from the acquired condition. And I think that in not very clear cases, the liquor analysis help the clinicians to address diagnosis and, of course, the treatment.
Okay, thank you very much. I think there are no more questions. we saved some time, but I think if there are no more, we can close this webinar session. Thank you to everyone for attending this session, and thank you, Anna Ardissone, for giving this very nice lecture. See you next time.
Thank you.
Thank you very much, Anna. Thank you, Carlo.
Thank you. Bye.
Goodbye.
Bye-bye.
Bye.